Hello and welcome back. It's 8 p.m. UK time. So, as you know, it is definitely time to start our live event tonight as well. And as you can see, we have another top fertility expert with us. So, I am very, very happy to have you here today. You here today, of course. As you can see, this is Dr. Valentine Akande. And hi, Dr. Valentine, how are you feeling tonight?
Great.
That's good. Perfect. Thank you so much for joining our Stronger Together initiative. We are definitely very happy to have you on board with us. And as you know, most of the Stronger Together events, all of those Stronger Together events have been brought to you just because we want to give you that opportunity to meet top fertility experts from different countries, but also we definitely want you to ask your questions. And today as well, you will have a chance to ask your questions so that Dr. Valentine can help you out. And before we start with Dr. Valentine's presentation, as always, I want to thank all of our ambassadors and partners for their support. And it is definitely a pleasure to cooperate with such a great bunch of people. So thank you so much for joining us and being with us through those Stronger Together events. And let me just introduce that Dr. Valentine Akande, as I've mentioned, he is actually the medical director and lead consultant at Bristol Centre for Reproductive Medicine. And he is a internationally recognized consultant gynecologist. So we are definitely very excited to have you with us. So thank you so much for joining our
Pleasure.
Stronger Together events, and of course for bringing this topic. As you know, the topic is how to improve your chances after failed or ICSI treatment. And of course, Dr. Valentine will be talking about this. And after his presentation, it will be time for your questions. So as always, go ahead and type those in, and Dr. Valentine will help you out. I have no doubt here as well. And well, that will be it from me at this point. Dr. Valentine, you're ready to start with your presentation then.
Great. Thank you
Wonderful.
very much. It's
Thank you so much.
can you confirm that you can see me and that I'm can you
Yes, I can
yeah?
see you very well,
Great.
and you can go ahead and
Yeah.
share your presentation. And just in case, let us know if you can hear us and see Dr.
Yeah.
Valentine. We just want to make sure all is good.
Yeah. So just to confirm, I'm now sharing my screen. Can you see it?
Wonderful. Not yet, so just if you can double check it.
Um I'm sharing the screen.
Yes, now it's we can see it, so you can just open your presentation. It
Can
will be okay.
you see
You
the
c-
presentation?
yes, I can see the presentation. Yes,
Perfect.
perfect. Thank you so much. Go ahead.
Great. Well, it's a pleasure to be here and to be speaking to all of you. I hope you find the presentation helpful and useful. And of course, I'd be delighted at the end to take any questions from you all. Um, and I will kick off by, of course, starting out with this image, which uh, is a reminder that we recognize that the work we do can have a profound effect on people's lives. We know how important it is to you, and we take it seriously. But also, the fact that many of you are listening to this presentation would also suggest that you may have encountered difficulties already with fertility treatment and therefore would want to know a bit more about how you can optimize or maximize your chances, particularly if you've already gone through IVF treatment already. Well, I'll start with some ABCs because I think part of this is really recognizing that there's no magic here. It is really about us experts dealing with your condition and giving you the best chance possible. There really is no magic. And part of what I will be talking about today really is providing you with a better understanding about fertility And then towards the end, we will focus on the things that might help improve your chances. And I'll just go back a little bit in history from 1866, and I say this because in the current situation there are so many tests out there, and we understand that when people have tried IVF, it hasn't worked. We always get the question: are there any tests that can be done and that would improve our chances? And I'll just go through some of these tests here, which we no longer do. This is not IVF, these are not IVF tests. These are just routine tests. These were postcoital tests, sperm antibody tests, chlamydia tests, etc., etc. And these days, if we really think about it, the two most important tests are the sperm test and the ultrasound scan. Yes, we do all other tests like FSH, sonohistograms, AMH tests, etc., etc. But if you really boil it down, the two most important tests are semen analysis to know that there's sperm there. And with a scan, you can actually tell quite a lot. A scan gives us so much information, and many of you may not be aware that a scan, if an accurate scan is done, you may not need an AMH test because a scan tells us how many eggs you have. And you could take it a step further. As long as you know there's sperm there, you don't even need to do a sperm count, because you can just do an ultrasound scan and just proceed with ICSI. So the way IVF has gone is actually we went from a stage where we were doing tests which were actually not really helpful and not reliable. And I'm saying this because nowadays there's so many other tests that are coming out, and people are saying they may be useful, but actually how useful are they? And this is where my job, or our jobs as fertility experts, is not to advise you just of the tests that are available, but also to advise you when not to have tests, because as many of you appreciate, having fertility tests can be quite expensive, and sometimes some tests are not appropriate. Well, let's pull back and just look at some simple things about the IVF process. For those of you who would have gone through IVF, you will recall that actually every stage is important, from the stimulation, from when we start you on medication. It's important that you're placed on the right medication as well as the right dose. That would lead to you producing a decent or good amount of follicles, and then also the doctor or specialist undertaking your egg collection also has to be proficient at the procedure in order that they're able to get the eggs out of these follicles. And then when you take it a step further, the quality of the lab is also very important, because everybody hears about ICSI, but ICSI is actually quite a delicate procedure, and if not undertaken with due care, there's a lot of damage that can happen with the needle that's used to undertake ICSI. So whilst it sounds very straightforward and simple, it isn't. You really need expert and competent people undertaking this. And then you get to the other stage where you've got the development of the embryo by, again, very competent and a competent embryologist, but also good quality standards in the laboratory. Everything matters: the temperature, the duration, the protocols, the media, etc. The media in which the embryos are developed, all these things matter. And of course, the other bit is actually the embryo transfer procedure. That's a very delicate procedure that needs to be undertaken again by an experienced individual. So all these factors in themselves, a problem at any of these stages can result in a reduced chance. And this here, for those of you who have undergone egg collection, this is how the egg collection procedure happens, where a needle goes through the vagina into the ovary, and that again is that's the embryo transfer. And then, of course, a lot of people talk about implantation, and implantation is important. And this here is the delicate embryo at the blastocyst stage, preparing to implant in the endometrium, otherwise known as the as the womb, as known as the womb lining. And there is a dialogue between the embryo here and the lining of the womb. They talk to each other, and the lining of the womb is able to recognize whether the embryo is normal or not. That is what, and sometimes there are problems with that receptivity, and that leads to embryos that are abnormal implanting, which then go on to miscarry. Or sometimes the lining of the womb has a problem that actually it is too selective, that actually even if you have a good embryo, it doesn't always allow that embryo to implant, or there could be other disruptions of the lining of the womb. And so this is an area we will focus on as the presentation goes along. So if we think about the complexity associated with this embryo implanting within the lining of the womb, there is the most important thing actually, which we think accounts for 60, if not 70% of the success, is actually the embryo. So the most important thing about implantation or your chances of success is really to do with the embryo. Because if you think about it, people talk about the embryo sticking or implanting, but actually it is about the embryo growing. Because if the embryo grows, it will continue to, it's very likely to implant. Many of you would have heard of something called an ectopic pregnancy. An ectopic pregnancy is when an embryo implants outside the womb. So it means it's implanted in an area where it shouldn't, and was actually it should have implanted normally in the lining of the womb. So that tells us that an embryo, if it's very strong and robust, can implant in places that are not even conducive. So the embryo, as long as it grows, very often would implant. So the critical thing is embryo development. And so therefore, I prefer to talk about embryo growth, because if an embryo grows, it's likely to implant. Then, of course, there are hormonal changes. You need to, the right hormonal levels will lead to preparation of the lining of the womb for implantation, just like different seasons lead to different plants growing at different times. So the right balance of hormones is important. And we know that immune responses are also important. The challenge we have is understanding the full immunology of fertility. And I will tell you that it is not as straightforward as is made out. It is a challenging area. There's still a lot to learn about immune responses. Many of us are aware that immune factors are likely to have an impact, but how we measure that and how we alter it, how we influence it, that is the challenge. And we haven't perfected that yet. And we're still at the stage where we understand these two more, and this is a growing area, and there's a lot of controversy in this area. Now let's look again at what happens naturally. So if you think about what happens at conception, so you ovulate, and very often fertilization will occur, but then prior to day 7 after ovulation, over 30% of the embryos do not get past that stage. Then we wait a little while longer, and before 14 days of ovulation, when you're just about to have a period, again, another 30% of embryos are lost. This is talking about natural conception. So this is what's called preclinical, and the pregnancy test tends to be positive around this area. So very often, a lot of people who test before their pregnancy test date will have positive pregnancy tests. And then, of course, it will not go past, they'll then have a period. And that's known as a biochemical pregnancy. So from this, you can recognize that about 60% of pregnancies are lost before you have the expected period date. And this is almost kind of similar to what happens in IVF, because when we undertake IVF, we see the embryo developing in this stage, we put it back in the womb, and then during that stage, unfortunately, not every embryo progresses. And then you go a bit further, people have a positive pregnancy test, that's great news. but we then recognize that another proportion of pregnancies will miscarry, and then at the top of the tree, eventually, having started here at the early stage of conception, only 30% lead to a live birth. And this is the natural progression. This is actually what happens for you um, um, in real life. And so biologically, as human beings, we are very efficient survivors. We are living longer and longer, but unfortunately, we're not very efficient reproducers. If you look at rabbits, they have about over 95% fertility rate, but if you look at humans, it's about 20 to 30% per cycle. So this is unfortunately natural. And so when we do things, we have to recognize what our starting point is. And it's sometimes very difficult to beat nature. Just like I also mentioned that as we grow older, there's certain things that happen, such as we get gray hair, there's changes in the skin with wrinkles, etc., etc. So if we look at implantation failure, there are two things. First of all, it's recognizing that there are competent embryos, because it's the competent embryos, and they're then selected by the endometrium, which also has to be receptive. So you need good quality embryos, and you also need a receptive endometrium. If you have a very unreceptive endometrium, even if you have a good quality embryo, chances of implantation are low. If you have a very um, selective endometrium, that means the lining of the womb is too choosy. Even if you have a good embryo, it might not implant. Now, again, if we look at the implantation window, it tends it's quite short. It's about somewhere between usually about 6 to 9 days post ovulation. This is what happens naturally. And so when we do IVF, what we're trying to do is trying to simulate what happens in a natural cycle. So the egg is released, it then gets fertilized in the fallopian tube, it then travels down and then implants in the womb around sometime between day 6 to day 9, and usually around day 8 or 9. So when your embryos are developing in the IVF laboratory, the laboratory uses an artificial incubator. The womb is a natural incubator, but also the embryos travel down, as you can see. At their different stages, there are more cells within the embryo. Now, the thing to understand about fertility, really, and this is perhaps one of the most important slides, is that fertility really is understanding what your chances are, or your probabilities, or what your prognosis is. That really is what it's about, because it's very rare that people are infertile. So I don't like using the words infertility, because there's hardly anybody we see who's infertile. Generally, when we see people, they have a degree of subfertility. And what we're trying to do is trying to increase their fertility. So technically, if you've been trying for a certain length of time and you haven't got pregnant, it means that your chances are lower. It doesn't mean you can't get pregnant, but it means something is reducing your chances. So say you've been trying for 2 years and you're 30 or 25, and you've been trying, then your chance of conceiving each month is about 1 in 20. So this is a dice with 20 sides. So our job is to try and understand why your chances are lower, and then really is to try and reduce the number of sides on the dice, and i.e. to bring you to a dice with fewer sides. Ideally, if you're 25 to 30, the success rates are about 50%. So we'll be taking you from a dice like this to a coin with two sides. And really, once you understand this concept, it answers a lot about natural conception. It also answers the question about IVF. Because if somebody tells you chance of IVF success at 25%, that means you've got a dice with four sides. And therefore, just like a dice or a coin, the more times you throw the dice, the more likely you are to get pregnant. That's why sometimes with fertility or implantation failure, it really is just about trying again and trying again. That is sometimes the most effective answer. But still, as clinicians or specialists, we still have a duty to try and understand why you may be not getting pregnant and what we can do to improve your chances. But that cannot take away the fact that sometimes it is just about throwing the dice again, and that way you increase your probabilities. So, what are the factors that actually affect your chances? Well, let's look at this slide here. This slide here looks at the number of eggs you have, the oocyte pools, and reproductive events. And here's a logarithmic scale where we have the number of eggs. And this is age 0 when you're born. Now, when you're born with about 2 million eggs. But guess what? When you're in your mother's tummy, at about 5 months, you had 5 to 7 million eggs. By the time you start having periods at the age of 10 to 14, you've got less than 500,000. So you haven't even ovulated once, and you started off with 5 million. By the time you start ovulating, you've got less than 500,000 eggs. By the time you are 37, you've got about 25,000, and by the time you reach the menopause, you've got less than 1,000. So you can see that there are things that happen in nature. Just like you would not expect a newborn baby to start walking or talking, and you would not expect a 95-year-old person to run a marathon. There are some things that happen physiologically, and it's very difficult to cheat nature. By the same token, it's really important to understand this, that there are some things that happen to our body in terms of the number of eggs. Now, eggs are different from sperm. You are born with the number of eggs you will have, and that number continues to go down. It's very different for sperm because you can continue to produce sperm, even though sperm quality can decline with age. An 80-year-old man, 70-something, can still produce sperm. So there is a difference between men and women. And the same thing, like if you pull out your hair, you can grow new hair. But if you pull out your teeth, you cannot grow new teeth if you're an adult. And it's the same thing with eggs. Egg numbers, you cannot grow new eggs. You've only got the eggs that you have left in your ovary. And this here is an example. When you're young, you've got lots of eggs, and when you're older, you've got fewer eggs in your ovaries. So this is an ovary of a much older person. This is an ovary in somebody who's got more eggs. And many of you would have heard of the AMH test, and this AMH test just shows you again what the average egg count is as you get older. The average egg count goes down. Now let's pull that all together again and look at what happens naturally, because we have to understand what happens naturally before we look at sophisticated things like IVF, because IVF is an artificial thing where we try and optimize your chances, but we still have to know what happens in normal circumstances. So this here is a graph looking at the likelihood of pregnancy and natural conception in women who are aged between 20 and 30. And what you find is that in the first month of trying, people who come off the pill, about a third will get pregnant. Within 3 months, about 2/3 will get pregnant, and within 6 months, 3/4. And if you wait a year, within 12 months, about 90% will get pregnant. If you wait another year, so 2 years, 95%. Now, the key thing here is this. If somebody gets pregnant in the 14th month, all they've done is they've continued to try. They have done nothing different apart from just had intercourse again. They've done nothing different month 14, from month 7, from month 8. All they've done is they've continued to try. So this is the important concept. The same with IVF, but the difficulty with IVF is that by the time you've had 3 cycles, or you begin to wonder, is there something else going on? And yes, there might be, but it's still important to understand the more times you throw the dice, the more chances, just like in natural conception. And by the same token, if somebody's been trying to conceive for 3 months and comes to us in the IVF clinic, we'll tell them to continue trying, because 3 months is too soon. We would ask them to try for a bit longer. And on the converse note, if somebody's tried IVF for 3 cycles or 2 cycles, we want to begin to think, is there something else wrong? And let's take this further and look at somebody who's been trying to get pregnant naturally according to age. So this line here is 12 months. And you can see that this black line here is for somebody who's 25. This blue line is for somebody who's 30. And they have about a 90% chance of getting pregnant within 12 months. If you're 35, your chances are 70%. And if you're 40, it's 50%. So you can see how important age is. And I say this because it's to emphasize that whilst we can do our best, we test, we don't have magic tools. We have things that we can do to optimize your chances, but it's understanding against what background we are doing that. And this again is an important slide, because even when we use the most sophisticated treatment, which is IVF, this is data from America looking at thousands of cycles. If we look at the chance of having a baby from 0% to 50%, you can see age 25 here, age 40, age 44. If you use your own eggs, you can see that the chances decline with advance in age. Now, so you can say that at 40, the chance of having a baby at 20-something percent, at 36, almost 40%, at 25, about 50%. So these data look at everybody who's at that age, and you can see that at 44, the chances of having a baby with your own eggs, about 4%. Now, the challenge with this data is that you can't get 4% of a baby or 20% of a baby. It either happens or it doesn't. So it again comes back to understanding that our job is to increase your chances. So I've had patients where I've said, right, they've got a very poor reserve, or they've got fibroids or cysts, and I say your chances are only 2% or so. And then they write to me about 6 months later that they've got pregnant, and that's fantastic news, because 2% does not mean 0. 2% means their chances are low, but as long as they keep trying, they'll continue to try. Conversely, if we tell somebody that their chances are 50 or 60%, it does not mean they'll get pregnant, but it does mean they're more likely to get pregnant. So if you look here at donated eggs is when we use eggs from younger people, usually under the age of 30. What happens there is that as long as we use eggs from younger women, even if you're 60 or 70, your chance of having a baby are about 50%. So it tells us that the egg quality is really the most important determinant of IVF success. And I cannot emphasize this enough, because of course there are lots of fertility tests out there, but we have to understand against what background we are working against. So this again is just an example of chances of live birth at 31, 37, and 40, and you can see there's stark differences. So somebody who's 37 is likely to need more time, more goes at IVF to have a baby than somebody at 31, and somebody at 40 would need many more goes to have the same chance of success. So in a way, that is one way of improving your chances. Um, the other thing to understand as well is the miscarriage rates um, go up dramatically. So in the previous slide, I was showing you live birth rates because many people get pregnant, but they miscarry. So here, this is again data from Scandinavia of um, quite a number of cycles. And at the age of 25, your risk of miscarriage is 12%, at 30, 15%, 35, about 20%. And at 40, you can see it goes up to 40%. So again, age is playing quite a significant effect. And at the age of 45, the risk of miscarriage is about 80%. So chances are probably better with donor eggs when you're in in the 45 age bracket. Sperm also is important. The quality does matter, and I think there is more emerging evidence that particular DNA fragmentation may be an important factor as well. Um, in the past, we thought everything depended on the egg, but there is more emerging evidence that perhaps the sperm does have an influence, still not as strong, not as profound an effect as the egg. And remember, the egg is much bigger than the sperm. So this egg still has the most important influence. These are normal sperm here, and these are abnormal sperm. And the tests that can be done, such as DNA fragmentation tests, that can identify um, um, tests that might be abnormal. I'll skip this slide because we already discussed IVF before. This here is just an example of how an embryo transfer is done. For those of you who may not be aware, it's often done under ultrasound guidance, so we ensure that the embryo is placed at the right position, right at the top. And again, this is an important factor that it's done by skilled people to make sure it goes to the right place. Now, the other thing and is a lot of people have what's called unexplained infertility. That means, or subfertility. That means we've done all the tests and they're completely normal. But when we undergo the IVF treatment, we then begin to see that there are problems with development of the embryo. So this, for example, are cartoons of showing what embryos look like. And these are all grade A embryos. These are grade AB. These are grade B. These are grade C, and these are grade D. So again, the quality of your embryos tends to determine um, the chances of implantation. Having said that, even if your embryos look normal, that doesn't always mean they're normal. The genetic content of the embryos is more important, and that's why sometimes things like pre-implantation genetic screening might be helpful. And these again are just looking at cartoons of quality of the embryo. So these are the type of, we're looking generally for grade A to grade B embryos. Grade D and grade E embryos really have a very, very low chance of implantation. And these are the ones that have a much better chance. And this is an example of a top quality embryo. This, if you look at the time over here, you can see the embryo development, and this helps us choose the best embryos to go back into your womb cavity. This is a top quality blastocyst on day 5, and unfortunately not every embryo will get to this stage. And once we've got a top quality embryo like this is the embryo that's transferred to your womb. And once it's placed in your womb, we just then hope that the womb will do its job, or the embryo will continue to grow. And that's where we're then lost with information until the day you do a pregnancy test. And there's little we can do about knowing what's happening to the embryo, apart from making sure that we've placed the embryo in the most conducive or best environment possible. So some other just really simple things. there is no such thing as a fertility diet, because what are the things you can do to improve your chances? However, there is emerging evidence that actually a Mediterranean diet might be beneficial. The other thing is, if you exercise, that's good, but too much exercise, if you're running a marathon, that can reduce the success of fertility treatment. You also don't want to smoke. Smoking reduces your chance by 50%, but not only smoking, but also being exposed to people who smoke. So, but also noxious substances. So in the laboratory, if you paint the rooms, the embryos are really sensitive, so you want to avoid strong perfumes or all that during treatment as well, because these noxious or what are called volatile organic compounds can have an influence or impact on chances of success. Well, we recognize how stressful fertility treatment can be, particularly when it doesn't work. And it'd be nice to get rid of all the stress. The good news is that stress does not appear to affect the chances of the success of IVF treatment, apart from if you stop having periods altogether, then we know there's a problem with ovulation, then that causes fertility problems. But in terms of the success rate, stress does not appear to have an impact. So what are the other things you can do? Well, there's more evidence now that vitamin D in particular is beneficial. Folic acid is helpful more for reducing miscarriage, but vitamin D, there's more evidence that people with lower vitamin D levels have a higher chance of implantation failure than people with good vitamin D levels. You don't want to be drinking more than 4 units of alcohol a week, and preferably less. So that's less than half a bottle, not more than 2 cups of coffee. And as I said, there is emerging evidence that a Mediterranean diet may be beneficial. If you have a poor ovarian reserve, and sometimes coenzyme Q10 may be beneficial, it is an antioxidant. If you have a very, very poor ovarian reserve, DHEA or testosterone may be beneficial, but you would need to speak to an expert to discuss how that's used or whether it is of benefit in your case. It doesn't work for everybody. It is not a standard recommendation, but sometimes if there's no other option, as long as you understand that it may not work, then and the side effects have been explained to you, may be reasonable to use. In terms of poor sperm quality, there are some male fertility supplements such as Impro or Fertilix that may improve sperm parameters. And the key question here is may. They don't always do that. So let's try and summarize and say, well, what are the causes of failure of IVF? Well, the most important actually is the embryo. And the embryo quality is really determined by the egg quality. So the younger you are, the better the egg quality, and therefore better the embryo quality. We know now that perhaps sperm quality accounts for somewhere between 10 to maybe 25% of the embryo quality, but it's mainly the egg quality. And in terms of the sperm quality can be assessed by sperm DNA fragmentation test. The challenge there is, if you do find a problem, what can you do? Well, you can take fertility supplements and have ICSI treatment instead of IVF. But generally, embryo quality is determined by egg quality, and the younger you are, the better the embryo quality. What of the womb lining? So if there are problems with the womb lining, for example, if you've got a polyp or you've got a fibroid or you've got adenomyosis, that's pretty straightforward and easy. Every clinician or specialist will be able to identify that. The challenge is where there are other subtle functional problems, such as receptivity, and that is where and there is emerging evidence that things such as an ERA, which is an endometrial receptivity array might be beneficial. We're coming to recognize now that infection can also play a part, and it depends on which studies you look at. So between 5 to 20% of women with implantation failure might have not so much as infection, but um, organisms within the womb cavity that can be identified as having an impact. There's also the microbiome. The microbiome means the organisms within the womb cavity, and there are also studies that suggest certain viruses as well can affect implantation. So problems with the HPV virus are associated, or chickenpox virus are associated with lower chances of implantation. And sometimes as well, there might be immune problems that are identified, although the data on this is still controversial and speculative. Then medical conditions, if you have got a severe thyroid problem and not mild, can affect implantations of uncontrolled diabetes, arthritis, lupus, stickiness of the blood as well. These are potential conditions, but these will need to be discussed with a specialist, and we wouldn't have time to go into each of these. And as well, if you have poor nutrition, if your general health is poor, um, or as I say, immune problems, although the immune issues are controversial and difficult to test and difficult to treat. So what are the tests we can do if we're looking into the womb cavity? Again, doing a hysteroscopy, which is putting a telescope in the womb, may be beneficial in certain circumstances. And this is where the skill of your specialist comes in, because our job is to advise you when to have some of these tests and when not to, because a hysteroscopy potentially can be an expensive operation. Thrombophilia testing as well as testing for stickiness of the blood. The evidence for that is not very strong. Immunological testing, again, there is some evidence that but again, if you are to have immunological testing, you need to go to a center that does it regularly and really understands it. Because if it were that straightforward, everybody will be doing it. But as many of you may be aware, most places aren't, because it is not that straightforward, and there are no easy tests that give you straightforward answers as to what needs to be done. Certainly doing genetics of parents of yours really doesn't tend to help. We see some places order these tests. They're quite expensive, and the vast majority of cases are not required. We've talked about sperm DNA fragmentation testing. There is emerging evidence that can be beneficial. One thing that we do recognize, and as I said, can affect somewhere between 5 to 20% of patients with is chronic endometritis, where there's mild inflammation or infection within the cavity, and this can be assessed by taking a biopsy of the womb. And there is now emergent evidence where there's endometrial dyssynchrony. And what that means is the lining of the womb is developed at a different stage from when the embryo is developed. So rather than them being synchronized, the embryo is put back at a wrong date, because the endometrium has not grown enough or has grown too far. Then other tests as well look at PGS, which is pre-implantation genetic testing for abnormal embryos. That can be beneficial, particularly in older people who've had recurrent miscarriages. So what are the treatments? Instead of saying endometrial injury, this should say endometrial scratch. And this, again, has become a bit more controversial recently, because there was a big study which suggested it doesn't make a difference. But there have been several studies that have suggested it's beneficial. So it's not there's still a bit of controversy. However, in situations where you've had more than 2 failed cycles, and you understand the risk, it probably, and you've had top quality blastocyst transfers, probably something worth considering. Aspirin, the evidence for aspirin does not seem to be strong. The same thing for heparin, although heparin does not tend to cause harm apart from an increased risk of bleeding. What many people are not aware is that aspirin actually increases your chance of miscarriage by about 5%. So again, if one's to use aspirin, one has to understand in which situations it is used. There's certain situations where aspirin is beneficial and others where it might be actually be harmful. Immune therapy, again, if you're to consider immune therapy, has to be done under expert guidance and somebody who really knows what they're doing. It is controversial, and many of the treatments are speculative. And these steroids and intralipids all fall under the guise of immune therapy. And it's like anything, if you're to give steroids, the truth is, for implantation to occur, you need some inflammation. So if you steroids suppress inflammation. So if you suppress inflammation too much, that can be that can counter the potential of implantation. And the analogy there would be like some plants like a lot of water, and some plants need less water. So um, there is no standard treatment for implantation failure. You have to look at each individual case on its own. So as a patient, we have to look at your whole history, what treatment you've had. We have to look at your full details. So steroids might be harmful, they might be beneficial. And the same thing with intralipids. The evidence around this as well is controversial, as is that with GCSF. There is more evidence suggesting that extra progesterone can be beneficial in some cases, and progesterone generally is administered vaginally, but also in some cases it needs to be administered by injection, and that can result in better success rates. And PGS we talked about, which is pre-implantation genetic screening. Now, I'm just going to kind of show you a bit to just explain how challenging fertility treatment can be. This is a true study published in 2011. It's a randomized controlled trial, So, and I'll tell you what happened here. They used a clown where at the time of embryo transfer, they used a control where they had 100 women randomly who did not have a clown in the room, and in 110 women, so similar numbers, they made sure there was a clown in the room to get the woman to laugh. And you can see that where there was a clown, the success rates were pregnancy rates were 36%, while where there was no clown, the pregnancy rates were 20%. So this suggests, if we were to follow this through, that at the time of embryo transfer, we potentially should have a clown in the room. But I'm not aware of anybody who's taken this forward. And I think this is just to convey how challenging sometimes doing studies in medicine can be, and how sometimes we deal with the results, and how do you explain a true study like this, which found benefit but has not been implemented elsewhere. I think we also just have to think again about the future. When I started IVF in the early 90s, success rates were not as good, and ICSI had only just come about. And where success rates, in particular young women, are really good. And we're moving more towards cryopreservation. That means freezing. But also the challenges we had before were about multiple pregnancy. These days, it's not often that we transfer more than one embryo, but we're getting the epigenetic issues. So with every advance, there are also some other issues to consider. So to summarize, we recognize that failed IVF can be challenging both for you, but also for the clinician or the expert. And it is sometimes not easy to know the answer as to why you might be having difficulty. It's sometimes to do with the embryos, sometimes to do with the lining of them. But we have a responsibility to do our best to give you the best chances of success, to make sure we've looked at all the possibilities. But having said that, there also has to be common sense, because if we were to do every single test on you, it will result in enormous cost, which is not always advantageous. And sometimes it really comes down to just probabilities. That means having another go. And as you could see from the present from the graphs I showed you earlier on, just having more goes actually is an important factor in improving your chances. And really, you want to make sure your treatment is personalized, so it is absolutely personalized to your circumstances, rather than you're just having the same as everybody else, and it's optimized by an expert. So on that note, I finished my presentation and very much hope that you've found it helpful. Thank you so much for listening, and again, I really hope with your fertility journey that it meets with success.
And wonderful. Thank you. Thank you so much for this brilliant presentation. Lots of details, lots of information, but so very useful. Thank you so much for that. And well, I'm not sure if you see this, but actually there is plenty of
Oh
questions
wow!
ready
I love
for
answering
you.
questions.
So
Absolutely love
yes, if you
it.
so you
Let's
will
go.
have a chance to answer. As you can
Yeah.
see, there are like lots and lots of those. So thank you so much already for those questions. And well, let's go ahead with them. And so the very first question is right here. How important is the grade of blastocyst?
Yeah. So the grade of the blastocyst is quite important, because um, now I'll just give you an example. So um, if you are to run a marathon or to go through some strenuous challenge, like play a difficult sports game, the younger you are and the fitter you are, the better. So the same applies to to embryos. So if we look at people who smoke, for example, the chances are reduced, but we all know that people who smoke can get pregnant. But what you find is you rarely find older people who smoke get pregnant. The younger people do, and that's because their embryos are more robust. But the grade of the embryo is also important, particularly for freezing, because the better the grade of the embryo, the more likely it is to be able to be frozen and to be thawed. So the grade is important. Having said that, we also know that embryo grading is dynamic, in that if you watch an embryo, the grade changes as you watch it. So if you watch it in time lapse, the grade can change, but it is important. But what's more important, as long as the grade is of blast is good, is actually the genetic material or the chromosomes, and that's why pre-implantation genetic screening comes in. But the grade of the embryo is important. The higher the grade, the more likely the implantation. Next question, please.
And wonderful. Thank you so much for your very first question. And let's have a look at the next one, of course, as well. And sorry, here it is. What are your thoughts on testing the uterine microbiome? Do you think it's worth testing? Can
Yeah.
bacteria really influence implantation?
So I think this is a really interesting question, because again, I've been in this business a long time, and I've seen all, I've seen some tests or some treatments that have come. Many of you would have heard about embryo glue. We used to use it, and now we don't. Many of you might have heard of assisted hatching. We used to use it, now we don't. And I think we're all trying to find an edge here. We're all trying to find something new um, that can potentially answer why you're not getting pregnant. And if we're able to treat it, what would give you a better chance? So the uterine microbiome, what is coming out from the research is that yes, an abnormal microbiome might, and there is likely to influence your chance of success. But actually, there's still quite a bit to do about understanding what a new normal microbiome is and what an abnormal, but also how you do the test. Because in order to do the test of the microbiome, you've actually got to go through the vagina and through the cervix into the womb, and it's quite easy to contaminate the specimen. I think actually where the evidence is more compelling, rather than testing the microbiome, is actually looking for inflammation, such as where you're testing um, for plasma cells or CD138. With the evidence there is much more compelling than the uterine microbiome. I think we have to wait and see before we start doing normal testing for the uterine microbiome. It's actually looking for inflammation, and the test to do is looking for chronic endometriosis, because there really is compelling evidence that if you treat that, your chances can be much better.
And wonderful. Thank you so much once again for your question and, of course, for your thorough answer to this one as well. And next one is, if you discover a polyp during the estrogen phase of a frozen embryo transfer, what would be the best thing to do?
So I think the answer is people would do different things. Again, the evidence for, and there's a question whether if it's a real polyp, as opposed to a polypoid lining of the womb. So there are few things that are important. One, the size and where it is, because if it is lower down in the cavity or towards the side, it may not be as important as, and also if it's really small. However, if it is big, certainly we would, in our practice, if we recognize it, we will notice it and we'll discuss the options with the patient, which will be one, depending on what we see, whether we recommend you stop the cycle and then it's removed, but then you need to have something called a hysteroscopy. But generally, if you see a polyp, it's not great news. You would rather you didn't have the polyp. So the best thing would be, ideally, if there's definite polyp, our normal practice is to offer removal as an option.
And again, thank you so much for this one as well. Okay, next one is up. Thank you for the presentation. I'm 40 and husband is 43. We had 3 rounds of ICSI and no embryos got to day 5 last
Yeah.
cycle. None of the eggs fertilized. Would the next round be the same? What would you suggest?
So this is a tricky one, and again, fertilization doesn't necessarily, um, um, your age is not a real factor in fertilization. Your age is more a factor in getting to day 5. So the big question here would be, which center this is happening, because again, different labs have different approaches and different um, quality standards. But certainly this needs to be looked at in greater detail. It's really difficult to give you an answer without, in this type of scenario has to be individualized. There's no generic answer, because in our center what we do in this type of case is we have what's called a multidisciplinary meeting, where all the embryologists and all the doctors, we all get together and we go through the case in detail. So it's not a monopoly of wisdom. It's not a single answer. Everybody puts their head in. We go through everything that's happened. So in this type of case, my suggestion with this needs a that whole team. You need to completely forensically go through your cycle and everything that's happened in the lab, because not having no eggs fertilizing, that's a concern.
And perfect. One more. Thank you so much for that one. Okay, this is a question that we receive many, 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 many times. So, do you believe egg quality can be improved?
Yeah. So I think whenever you ask that type of question in medicine, we have to believe that potentially it can be improved. For example, I'm getting older, everybody's getting older, but can I improve my fitness? Can I change my age? No. But can I potentially improve my health? Yes. And I think the same thing applies to eggs. But you cannot change the genetic content. You can change some things. So one analogy I use here is there's no amount of vitamins I'll take once you start getting gray hair. Or um, 5-10 years ago I didn't wear glasses, and then my eyesight changed, and I now have to wear glasses all the time. So there are some things you can slow the reversal, but it's very difficult to reverse, to bring egg quality. But you can slow things down, potentially improve stuff. So so for example, if you smoke, stopping smoking will certainly improve egg quality. If you drink a lot, that would improve. Coenzyme Q10, there is some evidence it's an antioxidant, can be beneficial. But the thing to appreciate is that when we say improve egg quality, it might improve it from here to here, but it's not going to improve it to there. And so you're, as long as you're making those marginal gains, but it's not going to go from here to here. So suddenly by taking these vitamins, and if you're 40, it's not going to make your eggs the quality or age of a 30-year-old. So that's the way to look at it.
And wonderful. Thank you so much for answering that question. And actually, there are some of the questions in regards to this. So I guess we can go to that one then. So does using is just what you have said. Does using ubiquinol and vitamin D help with equality?
Yeah, so I think ubiquinol, which is coenzyme Q10, yeah, there is some evidence that it can be beneficial and has to be taken 3 times a day. Ideally, and this is the important thing, if you're taking it to try and improve egg quality, you need to take it for 4 months. And the question is why for 4 months? Because the egg that's collected at IVF has actually started developing 4 months ago when it was recruited. So if you want to see the benefit, it has to be taken continuously for 4 months. And there is emerging evidence that vitamin D, as I said, can improve embryo quality, because embryo quality is reflective of egg quality. So yes, certainly vitamin D potentially can help. But I'll emphasize again, it's not going to improve it like this. It's going to improve it from here to maybe over there.
Wonderful. Thank you so much. This is a question that we do receive very, very often. And actually, I will go straight to the question about vitamin D, actually. Okay. So, what dosage of vitamin D would you recommend?
Yeah, I think it's really important here, to be very, very clear. If you have a vitamin D deficiency, then you need to be on a high level for a certain period of time. And then once your vitamin D levels are normal, you just need the standard supplementation, which you can get in any preconception vitamin. Overdosing in vitamin D can be harmful as well. So and so there are, if and what is recognized in particularly in winter, people don't get enough sunlight, so everybody should ideally take a bit of vitamin D. But if you can get a test either through your GP or clinic or whatever, and your levels are low, then you know you need to take higher supplements. But otherwise, all you need is the standard dose you can buy over the counter. You don't need a prescription for it, and generally, the serum levels, each laboratory has its value, but you want them above 50.
All right, excellent. Thank you so much. And as we are still having questions in regards to vitamin D, okay, here's the next one. So I'm a patient at BCRM and haven't had my vitamin D levels checked. Should
Yeah.
I request this?
No, I think so if you have concerns, and if you're, for example, not um, taking supplements. So for most people taking supplements, remember, most people take supplements, you don't need to have them checked. But if you have a poor diet and you're not exposed to sun, and you have and you're concerned and you're not taking supplements, then I would say go to your GP and have them checked, if you're concerned. But for people who've been taking preconception vitamins, and most people, we know are, then it's not a concern. These studies that have looked at vitamin D have looked at people who really have poor nutrition, and they've seen the difference, and in terms of miscarriage and potential fertility rates. So it's not a test that is done routinely in fertility clinics, and you don't really need to check your levels, because if you're taking the supplements, your vitamin D levels should be okay. It's just like you don't need your folic acid levels checked if you've been taking folic acid. But if you've not been taking any vitamins or preconception vitamins, and you've got a poor diet, and you've not exposed to sunlight, then yes, get your vitamin D levels checked. There are certain um, sections of society where people are covered up a lot and get no sunlight at all, that they need vitamin D levels checked. But generally, if you've been taking preconception vitamins, you shouldn't need your vitamin D levels checked.
Understood perfectly once again. Thanks a lot for that explanation. And as we are still in the topic on vitamin topic, I mean, how about B12?
Yeah. So again, this is vitamin B12. People should not take extra vitamin B12. Don't, unless you've been identified as having a B12 deficiency. And usually a B12 deficiency will be identified by a blood, you have a full blood count and it just shows you're anemic. Then one of the tests that's done is by your GP will be B12. But if you just take the standard preconception vitamins, really important, just the standard, that is more than enough. You don't, as long as you've got a good diet and you take standard preconception vitamins, you don't need to buy extra vitamins. I mean, there are studies now that actually show taking too many vitamins can be harmful. I'll give you an example. Most people don't know this. If men take extra folic acid every day, the risk of prostate cancer increases by 20%. So vitamins, in themselves, you just need a little extra supplements, but you don't need big doses unless you've already been identified as having a deficiency.
All right. Again, thank you a lot for explaining, and definitely it's good to know that. Okay, this is something that we don't hear quite often. So thanks a lot for that. And let's have a look. Of course, there are more questions coming up. Okay,
And
so
so, just to answer that
yeah.
question again, the reason I put in that slide things to do, vitamin D, folic acid, B12, is really you just need to the chemist and just buy the preconception vitamins that has. You'll find preconception vitamins have all those vitamins in. Those are the most important ones. But you don't need to buy extra unless you have a deficiency.
Wonderful. Understood, of course, perfectly. Thank you so much for adding this as well. All right, let's have a look at the next question. So I overstimulated in my last round 28 eggs down to 4 blastocysts and none resulted in pregnancy. Would overstimulation have impact
Yeah,
on my
there's yeah,
chances?
there's been quite a lot of stuff done on this. No, the overstimulation wouldn't have impacted on your chances. I imagine if you had 28 eggs, all your embryos would have been frozen. So that's just unfortunate. Um, but it's not the overstimulation it would have impacted on your chances. I'm sorry to hear that treatment didn't work for you.
All right. Thanks a lot for yet another question and, of course, your answer to that. Okay, let's have a look at the next question that we have. So, I am a patient at BCRM and about to start IVF. I've forgotten to ask whether embryo glue is automatically used or will the embryologist decide?
Yeah, so it's a good question, and there's one thing I often say is that the advice I give you today might be different from the advice I give you in 3 months, because we keep up to date with the latest data. So in the past, we, with all the evidence before, suggested that embryo glue was a good thing. So we used to recommend that patients had embryo glue, and then we stopped recommending when we analyzed our data in patients having fresh IVF cycles. So we said, well, we can't justify people taking embryo glue when we looked at our data and made no difference. But then we found that maybe it would make a difference in patients who had frozen embryo transfers. And then we found it, there was a slight difference. But then when we looked at it over a longer period of time, data, it made no difference. So as things stand now, we do not recommend people have embryo glue because we don't feel it's right that you pay for something that doesn't confer an advantage. And I tell you, the reason why it probably doesn't work in our setting is because the culture media that we use to create the embryos already contains embryo glue. So embryo glue is a very emotive word. The company call it embryo glue, so it makes it stick. Well, actually, embryo glue is all it is hyaluronic acid. That's all it is. It's nothing more than hyaluronic acid. And in fact, you don't want glue because you don't want an embryo to stick. You want an embryo to grow. So already in our culture media, that means where we grow the embryos, there's already hyaluronic acid. So maybe that's why, because we've already got that in our culture medium, you don't need the extra embryo glue. So the answer is yes, you can have embryo glue if you ask for it, if you want it, want to pay for it, but you will not find us recommending it to you.
And amazing. Thank you so much for explaining, because actually we did receive more questions on that, on embryo glue. So already, thank you so much for answering. Yes, how it works. And there is actually also a comment. Really appreciate your honesty to this question. So thank you so much as well for that. And let's have a look, because there are more and more of those questions coming up. Let's have a look at the next one. With normal hormone levels as a factor for successful implantation, what hormones should be checked and at what points?
So this almost means I have to give you a lecture on endocrinology, and I think it all depends on what protocol you are and what the philosophy of the clinic is, because in all honesty, for most cases, measuring the hormone levels for implantation makes absolutely no difference, because if you're following the protocols and um, um, the the patient is responding as expected, the hormone levels are not always the important thing. Because remember, hormone levels are just measuring what the hormone is. What actually is more important is what the response is. So, for example, let's take saying the amount of rain. Let's measure the amount of rain, and that would determine how much crops, how many plants or crops grow. Well, yes, if you have no rain, then you have no crops. But having too much rain as well does not necessarily mean you have plenty of crops. So the answer is each clinic should have its own protocols, and there will be a philosophy behind when hormones are measured. So I'll give you an example. So we are selective about when we measure hormones. Um, so there are certain indications that things are not going the way they should, or they're over responding. Then we measure your hormones. But just measuring your hormones every time, there's good evidence that that doesn't make it. Just adds potentially to the cost, and also adds to you having unnecessary blood tests. We noticed that there are a lot of places that when they have the blood test, they pay extra for the blood test. In our center, if you need the blood test, particularly estrogen, you don't need to pay for it. So we do it as necessary, but we don't normally do it routinely for everybody. It's again about being selective as to who needs it and when. We know that progesterone levels are important, for example, but we also know and I've published a paper on this in the past, if you have vaginal progesterone, you're never going to get the levels of progesterone that you get if you have progesterones given by injection. But studies have shown that when you have vaginal progesterone, there's higher levels of progesterone within the lining of the womb. But when you give it in by injection, it's high in the blood, but not higher in the womb. So again, it's really understanding the physiology behind it. So generally, each hospital or each clinic has its philosophy and approach about that. Our practice is we only do it when necessary, and we don't tend to routinely do hormone tests as treatment goes along unless required.
Amazing. Thank you so much once more for that. And of course, as you can see, there is a comment from the patient for you. Such a helpful explanation. Thank you. And let's have a look at the next question that we have. So, can stress and anxiety have a physiological effect on the success of IVF?
Yeah, the person who's done the most study, most research on this is Jackie Boivin in University of Cardiff. She's really is a pioneer in this area and has done quite a lot of research. And the reality is, for whatever reason, it would be nice to remove stress, whether you're having IVF or not. But we appreciate it is very stressful, and that's why they're counselors, and that's why we try and do our best. But the good news is that as long as it's not extreme stress, it does not seem to have an impact on the chances of success. So overall, the data does not shows that most people experience stress and anxiety. We know that, but excessive anxiety can potentially. There is some data that it might influence miscarriage, but in terms of fertility, it doesn't seem to have much of an effect. So that is good news, but yes, we do recognize that it'll be nice to remove the stress and anxiety for all.
All right, once more, thanks for yet another question. Of course, your help with this. Okay, next question is also ready. Usually, I have a little bit thin endometrium at time of ovulation, 6-7 millimeters. What do you recommend for next frozen embryo transfer? I'm thinking about natural cycle with few days estrogen support right before ovulation. Is that a good idea?
Yeah, I think again that's not physiological, because if you take then you're not having a natural cycle, because if you start having extra progesterone and extra estrogen, then you are changing what happens to the cycle naturally. The estrogen will then cause what's called a negative feedback and will prevent you ovulating. So if you have a natural cycle and then start estrogen support before ovulation, it might not quite work. So really, you either have a natural cycle or you have a program medicated cycle. In a natural cycle, it's all right to then have extra progesterone, but in a natural cycle, you really don't want to have extra estrogen. I think if your endometrium is 6 to 7 millimeters, then it is worth seeing in the natural cycle whether it's thicker, because sometimes surprisingly it is. But usually the approach where the endometrium is thin is actually to do a program medicated cycle where you have extra estrogen by mouth and also by patches. So you have a much higher dose. I hope that helps.
All right, of course. Thank you so much for that. And let's have a look. So, what will be the maximal age to do treatment with Onyx at your clinic?
Well, I think this is an interesting question, because I also remember when I started IVF, the maximum age was 45, and that sounds ridiculous now, but that's what it was then. And I think as things progress, things change. There was a time when people couldn't use donor sperm because of certain rules. So, but I also remember when I was used to give lectures for the British Fertility Society, and one of the sessions I used to do was to treat or not to treat. And so there's big audience. And what I'd always do, I gave those lectures on to treat or not to treat for I think about three years in a row. And I thought, well, I don't have a monopoly of wisdom. I have my views, but actually, this is sometimes this is a consent. One needs to take a consensual approach, test the temperature of what's going on. So I used to ask people the question, what is the age limit? And it was fascinating because you would have a range, and some people would say 48, some people would say um, 49 or whatever. But the key question was also asking them why. And what came out was actually nobody would treat above, in the UK, didn't find anybody who would treat above 50. Now that might change. And then there was, sorry, nobody said they would treat above the age of 51 with their with donor eggs or their own eggs or whatever. But with your own eggs, again, and the reason for the 51 is because that's the average age of the menopause. But the interesting thing is with your own eggs. Now, the HFEA or the regulator has clarified there's no age limit at which to treat patients. So each clinic has to take their own, has to have their own policy and also have good reasons for why they've chosen a certain age. And in our clinic, our approach is very simple. We would not recommend anybody having treatment with their own eggs after the age of 46. After the age of 46. Having said that, of course, we've treated women over the age of 46, but only under very strict conditions. That case is discussed by multidisciplinary group, and the patient who is above that age is very well counseled, because we think it is unethical to provide treatment to somebody with their own eggs when we know at the age of 47 the chances of getting pregnant are less than 1%. So it's very difficult to charge somebody a lot of money where you know the chances are less than 1%. So where we have done treatment, somebody's 47, for example, they with their own eggs, they've already been pregnant before, or they've had a miscarriage or something like that, and they've really been counseled. But so 47 is just about the limit, but our limit is 46. And anybody who's over 46 has to go to a multidisciplinary meeting for discussion. So that's the approach. That's the approach we take.
And excellent. Thank you so much once again, of course, for a thorough answer to yet another question. And let's have a look at the next one. So, could doing numerous treatment cycles be a concern knowing the high amount of drugs used during stimulation?
Absolutely. I think the fundamental point here really is that for any situation, you want to use as you want to avoid medication if possible. You want to also avoid fertility treatment, and it's always that balance between what are we trying to achieve and what are the risks with achieving that. So you're really having to work those out. Now, the what's interesting if you look at is Alistair Sutcliffe, who's done the most research on this in this area, and he's looked at he's done the epidemiological studies. And what's interesting is, forgetting about stimulation, it just seems that anybody who has fertility problems just sometimes has some higher risk of gynecological problems. But yes, I think there is no question that if you have 6 cycles of IVF, then your risks are higher. And it's like, it's then a balance. Do you what are those risks? Well, the main risk with cancer, because that's the one that people worry about, was that there's a stimulation drug called clomiphene, which we still use, which is associated with a higher risk of ovarian cancer. But the interesting history to this is, I still remember the days when IVF was not routinely available, And the standard thing in gynecology clinics was that if somebody was trying to get pregnant and they couldn't have IVF or whatever, they used to be on clomiphene for sometimes 4 years in a row, because there was no other treatment for them. So they were stimulating their ovaries continuously for 4 years. So of course, in those days, there were more problems um, with cysts and cancer of the ovaries. And that's one of the reasons why these days we don't use clomiphene for more than 6 cycles, or certainly a maximum of 12 cycles in certain situations. So really, it's about balancing. It's about balancing those risks. And it's not about the drugs you use. It's actually about your stimulation. It's not sorry not the it's not about stimulate, it's about how you respond to the drugs, because you can be on a very high dose of drugs. So if we gave a menopausal woman a very high dose of drugs, um, it is not going to do anything to her ovaries, because her ovaries won't respond. So it's not the dose of drugs, it's the response to drugs. So actually as well, we try and take measures to minimize you having overstimulate and being overstimulated. So in our clinic, we practice what's called appropriate stimulation. And so that means sometimes people get mild stimulation. We just don't call it mild stimulation. We just do that as we see fit, that actually we try and do what's right in terms of creating an appropriate response. And sometimes people still do over respond. That's the nature of people's ovaries being more sensitive. And sometimes you find that um, that happens. So, yes, if you're having numerous cycles, like 6 cycles, that's a concern. But for most people, having a few cycles, it's unlikely to be a major concern. And that's more of a concern if they have ovarian cysts. Thank you.
And thank you once more for that. Next question is, so what are your thoughts on PGS testing after 4 early miscarriages, all IVF conceived at BCRM?
Yeah. So again, the big question here now is your age, and where if you've had um, 4 miscarriages, that is now something to consider and to discuss. And it also would depend, if you've had 4 miscarriages, we would hope that one of them would have been tested, because if you've had one of the miscarriages tested and it's shown an abnormal pregnancy, that it gives a more compelling reason um, for for you to have PGS. So if you're over 37 and you've had 4 early miscarriages, then yes, PGS is something to strongly consider. And I think one thing to mention about PGS is that PGS does not make an abnormal embryo normal. PGS just identifies abnormal embryos so we don't place it back. Unfortunately, we find sometimes when we do PGS, we had a patient the other day where we got 8 top quality blastocysts, but all of them were abnormal, and that's tragic. A really difficult situation, but at least it gave an answer. So unfortunately, that patient didn't have an embryo transfer in that cycle. And in another case, we got all embryos were normal. So I sometimes tend to do an experiment with patients. I say, look, I've got a drawer on my left hand side, and what is in the drawer. Now, I know what's in the drawer, and you might guess that it might be pens, papers, paper clips, but until you open it, you're not absolutely sure. And I think the same thing, PGS testing certainly now would be something to consider, where you've had four, because then you would have um, you would have an answer. But I always also say, in these circumstances, there are 3 things to consider. One is the technical advice, and that has to be individualized to your personal circumstances. The second is the financial, because PGS is expensive, and the third is the emotional decision you make, because people might choose make different choices or different decision presented with the same information. Somebody might buy a yellow Mercedes, somebody might buy a pink Volvo, etc., etc.
And wonderful. Once more, thanks a lot for this. Next question is a bit of a longer question. So I have been advised I have unexplained infertility based solely on normal day 3 blood test after trying for 2.5 years. So it's great to hear you say infertility is not common. I started trying when I was 39 and just turned 42, so age is a factor. At 41, I did conceive and pregnancy was ectopic. I have had one round of IVF and had a good quality blastocyst transferred, but no implantation. Would you recommend some other testing? If yes, what testing, or just try IVF again?
That's a really good question, and I will just clarify. Um, so, just in the part where I said I don't believe in infertility, as in infertility means you can't get pregnant. I rather use the word subfertility. So, um, actually, to clarify, subfertility, or what many people call infertility, is actually really common in that subfertility, 1 in 6 couples present to the GP or to hospitals for advice, and 1 in 4 couples experience difficulty. So subfertility is common, but infertility, and what I mean by infertility is that where you actually cannot get pregnant at all, is very rare. Now, clearly, if you've had a hysterectomy or your testicles have been removed, then you are infertile. Now, in your case, you've asked, you're at 41, you conceived, pregnancy was ectopic, and you had one round of IVF and a good quality blast, but no implantation. Would you recommend other tests? Again, um, after one cycle of IVF, it probably just is bad luck, because we know you can get pregnant in that you've proven you can get pregnant with an ectopic pregnancy. And a good quality blastocyst does not mean that blastocyst was normal. At the age of 41, the chance of that blastocyst being normal is less than 40%. So even though it looks normal, it might still be abnormal. So um, in terms of yes, the answer really would be about most likely to try again, because it's really most likely that was just the quality of the embryo, not necessarily blastocyst, but quality in terms of chromosomes that PGS might be able to identify.
Wonderful. Thank you once more for yet another question, of course, as well. Next question is also, is there a test to check quality? I think all mine are really poor. Even the HEA didn't help.
Yeah, so I suppose what you mean is check quality of the eggs. So the simple answer here is this. Um, One thing we can do is check the numbers, so quantity, and we do that by a scan or by an AMH. So it just gives us an idea of quantity. Quality is different. Um, Within your eggs, within your ovaries, you've got good eggs and not so good eggs. When you're young, you've got a higher proportion of very good eggs and lower proportion of poor quality eggs. When you're older, like 50, most of your eggs are poor quality, and it's very unlikely you have good quality eggs. So as you get older, that there's a change in the proportion. Now, people ask this question: can you check the quality? The answer is, um, if you've had IVF and created embryos, that in itself is a check. That is, IVF is a treatment, but actually it's also a very sophisticated test because you've got the embryos and eggs in front of you. And the other thing is each egg is different. Now, those of you who have brothers or sisters would know that very often you're different from your brother or sister, and that means you came from a different egg. So if you test an egg, very often you damage that egg. So once you test an egg, that's it. So there's no way to test eggs. It's all about probabilities and again about luck. And that hopefully the egg that's fertilized that time is a good quality egg. And what we need to do is optimize your chances with luck, but sometimes accept that your chances, unfortunately, may be low. And biologically, there's sometimes not much we can do about that. and therefore, in those circumstances, one may need to consider egg donation. And as I mentioned earlier on, egg donation, your chances with donor eggs is 50%, and chances with your own eggs might be lower. Say if you're 44, chances are less than 4%. So um, your chances definitely will be better with donor eggs. And you're right in with DHEA. What in my experience, I've found in about 50% of people it makes absolutely no difference. In some, it makes a little difference, and very rarely it makes a huge difference for some people.
And thank you once more for that. And actually, there is a follow up from the very same patient. If you can comment on that, does egg have DNA fragmentation too?
No, no, because at the moment, no, you because when you eggs are really fragile. They're really, really, really fragile. Remember, most people are not aware that the average sperm count is 250 million. That's 250 million sperm. So when sperm are stressed, then they leave these little fragments of DNA which you can test. With eggs, when we do egg collections, we're only getting somewhere between 0 maximum 20 eggs. We aim for about 10 eggs. So no, you don't. They're not. It's not the same. So you don't do DNA fragmentation on eggs.
Excellent. Thank you so much for the clarification to this one as well. Next question, again, a little bit of a longer question. I have been diagnosed with mild form of adenomyosis and abnormal shape of uterus. It reminiscent of a heart shape might form. What these abnormalities mean for my pregnancy chances? It seems that implantation can be a big problem in my situation. I'm very worried about this.
So very simple answer. Number one is I would not worry too much. That's the take home message. The bit behind it is this. Like everything, there's a range. There is a normal range, and sometimes you have little degrees of abnormality. And the question then is, okay, if you've got a mild form of adenomyosis, that is so common. Many people have a mild form of adenomyosis. The abnormal shape, if it's only 3 to 4 millimeters, that actually is within the normal range. So if it's only 3 to 4, that is within the normal range, and I would not recommend doing anything about it. Um, at that type of level, it's within the normal range. So I would not be worried. Based on this information that you have provided here, carry on with confidence if it's only mild endometriosis and adenomyosis and only 3 to 4 millimeters. Because surgically, I undertake surgery on the womb, but in this type of scenario, I would not. You would not be the type of patient I would recommend surgery. Because you've got a tool does not mean you should use it. There are some people who might do, but I certainly would not recommend doing anything in these circumstances.
Understood perfectly. Of course, again, thank you so much for that. And there are some questions left, of course. We will be slowly finishing, but I guess, Dr. Valentine, you still have some time to answer some of those, right?
Absolutely. Real pleasure.
Happy to hear that. Okay, just wanted to check in. But of course, let's have a look at the next question. My doctor suggested the long protocol, 3 weeks. The first 8 days were going to be sorry, nasal spray. I'm not sure. Sorry here. Now they say I can skip these first 8 days. I don't know why. What difference would that make?
It's really difficult to um, I mean, there must be a reason. The thing about the long protocol actually is quite flexible. You can be on the Cineral spray for 6 weeks or 3 weeks or 2 weeks, but usually you need to take it for minimum. Generally, if you're on the long protocol, you need to take it generally for a minimum of about 2 weeks to get what's called down regulation. So I think the answer really is that without knowing more about what, or it might be they've changed something else and they've given you a flare protocol or something. Um, I think this question should be directed at the clinic or to your specialist. I really can't comment. It might be they're doing, there are lots of tweaks to protocols, and sometimes there's no disadvantage. So I won't be too alarmed, but you need to direct the question to them.
Of course. Thank you so much still for that question, and of course for your advice on that as well. And there is another question from the very same patient. What about green tea? A day, 1 cup of green tea a day, does
Yeah.
it decrease
No,
egg quality?
it's a good question, and I think green tea has antioxidants. So, but green tea also contains caffeine. So as long as you're not taking more than cups of um, two caffeinated drinks a day, you're likely to be fine. So it's unlikely to decrease, or I'm certainly not aware of the evidence that it does decrease egg quality.
All right. Thank you for the clarification to yet another question. And next one is, when would you start thinking an ERA test would be appropriate?
Yeah.
Appropriate.
So, question here is when to start thinking an ERA test would be appropriate. I think that's again, it's a really interesting question because um, we thought the ERA test would be a fantastic test. It came out early last decade, and it's only now the evidence is suggesting that might be beneficial. And I think one of the problems we have with the test is that it's quite expensive. Um, so I mentioned to you earlier on, I've been in this business a long time. I've seen tests come and go and all that. So I think the jury is still out there, and but it does. There is some evidence, and we do offer the test, but we're very selective. And I think we look at your cases individually. So, for example, if you've had failed implantation because your embryo quality is poor, then I would not recommend an ERA test. But if you're young, or certainly are not too old, and the embryos were top quality and implantation is not occurring, then you have to begin to think about the endometrium. So those are the type of instances where one might begin to look at that.
Wonderful. Thank you once more for that. And I have heard that ladies 40 plus menopause with gonal F can be better than menopause
Yeah,
alone. What are your thoughts?
yeah. So again, these are all interesting things, and I mean, I must say, I there was something about that in the past. I've tried it. I must say, I've seen no difference. Um, so, but again, these are tweaks. They're not going to make huge differences. Um, yes, you can individual. It's not going to be harmful, but there's no compelling evidence that mixing the two can is necessarily beneficial. But there's certainly no harm in doing both. And there has been some speculation that it might be, but actually, as I said, I've tried it as well and haven't noticed much difference. And now, generally, tend to choose one or the other, and in some cases, we'd use one, and if things don't work, then you swap to the other the next time. But generally, they have similar effects. The evidence that one's definitely better than the other um, is not that compelling.
And thank you once more for that. And there is another question from Karen. Okay, so let me go straight to that one. So I follow a Mediterranean diet with a calorie deficit to lower BMI. I have been advised by acupuncturists that my body does not absorb nutrition very well. I am worried this can impact fertility equality. Is there a way to test how nutrients are absorbed, and should I be concerned about that?
I think I'll just be very clear. I'm not a nutritionist, so I can't comment too much about how she's come to that conclusion. I mean, I have seen some very interesting things sometimes that patients present after being to some non-medical specialist, which I would, which I'm sometimes concerned about how they've presented that. But and what is very clear is that if you have a low BMI, particularly if your BMI is over 19, is lower than 19, your chances will be much lower. If it's lower than 17, even lower still. So you find at the extremes of BMI, if your BMI is too high or too low, then your chances are affected. And sometimes it's not, it's actually the microenvironment of where the egg is developing that can affect. But also, if you mentioned you've got a negative energy balance, or you're in a calorie deficit, then it's not only just the nutrients, but also we know that you need a balanced diet. There's good evidence that you need carbs, fats, and protein. And what we also recognize now is that it's not just about your diet. Sometimes it's actually about your genes, because there are some people, if you just remove carbs from them or even lowered their carbs, they stop having periods. And some other people, you just remove fats from them, they stop having periods. While other people on the same diet, there'll be no change. So people's genetics also determine their response. Some people exercise a lot, has no effect on their egg quality or embryo quality. While other people, you see they exercise a bit, and we look at their quality in the embryos, is really poor. They stop exercising, then the embryo quality becomes better. But again, it takes 4 months. So if one's going to make a change to that, because it takes 4 months for the eggs to develop. So if you make any dramatic change um, to your diet or exercise regime that's supposed to affect egg quality, ideally you want it to be for about 3 or 4 months.
And wonderful. Once again, thanks a lot for yet another question, and of course, for your answer. And there is a thank you, so interesting to know from Karen for you as well. Okay, and let's have a look, of course, at the next question that we have right here. I was told that FSH dose daily of 300 units is the higher dose that the ovaries can take. What are your thoughts?
Yeah, so it's a good question, and actually, um, that is about right. That 300 is usually generally the maximum dose. There is little evidence saying that going above 2 to 5 confers benefit, but we do know that 300 is about the maximum dose. There are some places that prescribe 600. In our center, in rare instances, we go to 450. But generally, 300 is the max we go based on the evidence. There is some evidence that going to 450 can be beneficial in some patients, and that's the thing. You don't know which patients that um, those are until you tried. But generally, 300 is really in most cases about the max, and in some cases, rare cases, you'd go above that. But 300 should be the standard maximum dose. So I would agree with that, and the evidence supports that. But in some people, going higher can be beneficial, but for the majority, 300 is the answer.
Wonderful, thank you for that. And how common is poor synchronization between embryo and the endometrium?
Yeah, it's a very good question, because the answer is until the studies are done, nobody really knows. So this is where the ERA test has come about, and saying that there is poor synchronization, and it is, as to do the ERA test is really expensive. So it's very difficult to know what the prevalence is. And I think the other thing we don't know, or is that if you have poor synchronization in this cycle, does that mean it'll be poor synchronization in the next cycle? Because the next cycle might be completely normal. So I think these are questions that really need to be answered. But this is a new area of research, and we're only still in the early days of it, and we might have more answers in a few years' time. But how common it is, we don't know.
All right, of course, thank you so much once more for that question and your answer to this one. And let's have a look, okay? You mentioned inflammation is necessary for implantation. Does that mean that I can before implantation treat myself to some sugar?
Um, when you say sugar, I take you mean sugar.
Sorry,
Yeah.
there is a follow-up. Sugar,
Yeah.
white bread, and other inflammatory food.
Yeah. So I think when we use when I talk about inflammation, I'm not talking about generalized inflammation. I'm talking about inflammation as to where the embryo is attaching. No, so no, that's not an answer to take the sugar. So the answer no. It's about local inflammation, not generalized inflammation. It's just like if you have a bee sting here, you might have, or insect bite, you have local inflammation, and so, but you don't want generalized inflammation.
And excellent. Thanks one more time for that, of course. Let's have a look, of course. So the next question, sorry, there are some more of those. It's about aspirin, actually. What are these situations when aspirin could be helpful?
Yeah, so certain situations where, for example, if you've got a rheumatic condition and you're already on aspirin, then you need to take it. Um, if you have a phospholipid antibody syndrome or lupus, then you need to take it. If you have a very high platelet count, which will be seen on your full blood count, or if you have a very high red cell count, and those are the situations where aspirin potentially can be helpful.
And thank you once more for that. Okay, next question, definitely an interesting one. What is your vision on fertility treatment in the next 10 to 15 years?
Yeah, so I think what's interesting at every stage, there are sometimes gradual improvements, and there's sometimes there will be a big leap. So IVF was a big leap, and then another big leap was having ICSI. I still remember the days when there was no ICSI, and the men who had sperm problems had to use donor sperm. And I think another big leap has been going to blastocyst culture, because when I started, we used to put embryos back always on day 2 or day 3. And now we tend to put embryos back on day 5. And I think there are a lot of there there's a lot of talk about the testing, like non-invasive testing, but I think that's going to be tricky. I think the epigenetics is interesting. I think how we can improve the quality of the eggs, and I'm not sure um, how that is easily achievable, because if you think about the way the egg is structured, you've got the nucleus, or where the center of the cell is, and then you've got the mitochondria. The mitochondria are like the batteries, and whether there will be progress in how we can deal with that. But again, we've always got to be careful when we interfere in certain things of in nature. What are the long-term effects? So I think it's very exciting. There's lots of progress. There are lots of people doing exciting research, but the further we get, there are also likely to be downsides, which we will find later on. Like, we're just beginning to see that sometimes with frozen embryo transfers, it might be that there's a slightly higher risk of having higher blood pressure in pregnancy. These are things that are emerging um, with fertility treatment. So I think certainly there will be more preservation. It'll be moving more towards people will be freezing, like to be freezing more eggs. The technology there has advanced dramatically, and it's when I started doing fertility, we weren't treating. It was not legal to treat single women or same-sex couples. That has changed. If people are living to 150, then fertility in 20, 30 years will be different. People might be treated at later ages, but I think in the present, there's still a lot to learn. There's still a lot of exciting research areas. How can we improve implantation? Many of you have alluded to improve egg quality, because most people would rather use their own genetic material rather than donor eggs. And is there something in many years' time that can be done about the mitochondria, which are the batteries that keep the embryos and the eggs young? So we'll see. But certainly at this stage, we're also not aware of things that where you can't create new eggs in your ovaries, because that's just physiologically at the moment not possible.
And thank you so much for that. And I thank you for the question, because this is a question that we can have another webinar on, that's for sure. And it's definitely interesting to hear what you have to say about that. So thank you so much for that. And well, let's have a look. As I mentioned, there are like a few questions left, and we will be finishing. Next question is the test for inflammation a blood test? Can this same test detect endometriosis, if I understood this correctly?
Yeah. So good question. Just to be clear, it's not a blood test, because if you have inflammation that's detected in your blood, that means it's got everywhere. So it's systemic, and that means you have an infection that's affected your whole body. So this is about infection that is local and contained within your womb cavity, or the lining of the womb. The lining of the womb is known as the endometrium. So the lining of the womb is known as endometrium. When you have inflammation or infection of the lining of the womb, it's known as endometritis. So endometritis or chronic endometritis is inflammation of the lining of the womb. And that we can test that by taking a biopsy from the lining of the womb. Endometriosis is when you have the lining of the womb outside the womb, so in the pelvis, around the ovaries, around the bowel, etc. So endometriosis is different from endometritis. Endometritis is inflammation of the lining of the womb in the womb. Endometriosis is when you've got the lining of the womb outside the womb that's causing inflammation in other areas of the body.
Excellent. Thank you once more for that clarification. Okay, next question. What's your thoughts on flu and COVID vaccine and the effect on equality?
I think the answer is it will only be thoughts rather than evidence. And as a clinician, as a scientist, it would be um, helpful to wait for the evidence. The answer is we don't know. We really don't know. It will be total speculation. Sometimes you find it might reduce your chances, and other times you might find it improves the chances. So the honest answer is I don't know. It will depend on, the way the vaccine, what type of response it initiates. Does it cause a systemic response, or that's transient, or you know, or does it just lead to the creation of antibodies? If it just leads to the creation of antibodies, then that's fine. That shouldn't be a problem. But if it causes a general systemic effect, then that might be different. So the answer is I don't know. I suspect um, when they provide the vaccine, they will provide a bit more information on whether you should be taking it if you're preparing for a pregnancy. But I doubt very much that will have any effect on egg quality, because the egg is protected and doesn't tend to be affected by systemic inflammation.
Excellent. Thank you so much once more. Okay. Next question is, so how soon after an early miscarriage should you try IVF again?
Yeah, so physiologically, it doesn't make a difference as long as you've had a period after that miscarriage and you're emotionally prepared to go through IVF. So it really is up to you. There's not much evidence either way. So it really is, are you mentally prepared for it? So you've had the miscarriage, I'd wait at least another period before you start going for IVF.
Excellent. Thank you so much once more. Okay, next one is definitely an interesting question. What is one miracle story that you have experienced during the last years helping women to conceive?
Well, I think there are two that stand out for me. There's one that's a patient with a poor reserve, and she had very high FSH, and we got stimulated her one follicle, one egg, one baby. Then came again, high FSH, stimulated her one follicle, one egg, one baby. And that's quite interesting. And the other one was somebody who came to see me after 19 miscarriages, and but this is not IVF, but they put on, again, I can't say that it was the drug regime we used, but he then ended up having a baby after that. So those are two that stand out.
Okay, again, thank you so much for sharing, of course, and your question. And well, there are some comments, of course, right here. Thank you. And wow, fantastic. It's in regards to, of course, the previous question. And let's have a look. This is, again, another question. I recently tested positive
And
for
Caroline, I
COVID.
can't hear you properly. Your voice is crackling, but I don't know.
Okay, I hope you do hear me right now. I recently tested positive for COVID-19. Although I was lucky, it was really mild case. I was hoping to start my third round of IVF at BCRM, sorry, in December, January. But would you recommend waiting
Yeah.
longer to fully recover?
So the question is, you've tested positive risk for COVID-19. The question is, how long ago? Are you clear of the disease? Do you have any? Because you have to be well to proceed with IVF treatment. So each case has to be individualized. Because again, there are some people who've suffered ill effects of COVID for months. So we would then not recommend you go ahead. But if it's a really mild case and you're absolutely fine, then yes, as far as we know, and you're negative, then it's all right to proceed with treatment.
Wonderful. And you can see the comment, I'm feeling fine and recent test last week was negative. Thank you. All right. Next question is right here as well. So, what would be a decent AMH level for a woman of 36-year-old?
Yeah. So the key thing, I know this is not what people like to hear, but the key thing is that AMH is not a definitive test because people want to use numbers. AMH is not a fertility test. We all thought it would be a fertility test, but it is not a fertility test. And some things I'll say now might surprise you. AMH really is just a test to give us an idea of your egg numbers so that we can put you on the right dose of stimulation for IVF. It is not a fertility test. A high AMH level does not mean high fertility. In fact, two studies have shown that your AMH level has no correlation between your chance of conceiving naturally or not, whether you conceive naturally or not. In fact, if your AMH levels are higher, it seems you have a lower chance of getting pregnant than if your AMH is lower. And I think that the reason for that, and many people will not be aware, is that if you have a very high AMH level, it means you've got polycystic ovaries, because AMH just counts the number of eggs, and when you have polycystic ovaries, it means you've got um, um, a lot of eggs. Now, the most important thing about AMH is whether your levels are high, normal, or low. That's the most important thing. The actual level, it's is not as important. Yes, it's a helpful guide, and we use it, and because you've got to use something, but we use your AMH. We also use your scan to decide what your reserve is. Um, And the other thing, so if you do an AMH level today and you repeated it in 2 weeks' time, sometimes you get a slightly different result. But at 36, your AMH level probably will be in the region of 10 or thereabouts picomoles per liter. But that's the average. You've got to look at a range. There's a whole range, and the range will go from about 3 or thereabouts to much higher levels. There's a chart that's used to look at that. But the most important thing, are you having regular periods, and is your level within the normal range? Don't be too worried about the specific number itself. A lot of people tend to worry about it, and some people ask, can I have my AMH level checked after they've had IVF? Absolutely, very happy to do that, but it makes no difference, because the most important test is how you responded to IVF. Because once you've had IVF treatment, we can see how your ovaries are responding. That is the real test, not your AMH levels. It's just like um, if you're driving on the street, nobody asks you to do your driving test again, because you've already done your driving test and you've passed. Now, actually, what's important is whether you can drive a car properly. And so the same thing, we're looking, the whole point of the AMH test is not about your fertility, it's about how you respond. And there are many studies now that have shown that AMH does not really predict the chances of implantation with IVF treatment, but it helps us determine how many eggs we're likely to get from you.
Amazing. Thank you. Thank you so much for explaining how it actually works. And it's definitely something that is good to know. And of course, there is a thank you from the patient right here as well. Okay. Next question is up. So here it is. As it can take 4 months from recruitment of egg to collection of egg, does this suggest that where multiple IVF cycles are required, the cycles be spread out approximately 4 months apart to avoid risk to the developing eggs, or does it make no difference to doing back-to-back cycles?
Yeah, it shouldn't. It's very rare that people do back-to-back cycles, but it shouldn't make any difference. The key thing, if you remember what I said about the 4 months, is if you have a problem with your egg reserve, or there's been an insult to the ovaries, such as you've undertaken a marathon, and or you've had a very severe illness, where you've lost weight and you've got a calorific deficit, then you need 4 months to replenish that. And then, as long as you continue to take that replenishment, it will be of benefit to the other. It will be of benefit to the other follicles. I don't know how the easy way to explain this, but ovaries develop in cohorts. So most of the eggs are resting. Then they get to a stage almost like nursery school, where they rest. Then they go to primary school. Then they go to secondary school. Then they go to the stage where they're recruited. So as long as you've prepared, it's almost like if you provide education from an early stage and you continue to do that for everybody, then the output, how educated you are after you go through secondary school, etc., is better. So you can continue to put people through primary school, secondary school simultaneously. But it's if, for example, you have a very low body mass index, or you're trying DHEA or coenzyme Q, then you really want to have taken that at least for 4 months before, so that it's in your system. But it shouldn't affect back-to-back cycles for most people. It should not affect, but it's very rare that people have back-to-back cycles, where you don't need to wait 4 months. The downside waiting 4 months, particularly if you have a low reserve, is your chances go down. But having said, it's very rare that people have more than 3 cycles in a year. It's rare, because it's emotionally, financially, and otherwise quite challenging.
And thank you once more for that. Next question again. We had 3 failed IVF and decided to go with egg donor. We had got 3 blastocysts with the egg donor, and the first transfer was unsuccessful. We have 2 blastocysts left. Should I do other tests to determine why my womb is unreceptive? There are so many. I find it hard to determine the right test to do. Is there any one test you would recommend out of all you
Yeah.
discussed?
So I think the answer here, and this is the answer for this type of question, is unfortunately you need to have a proper consultation, and all the forensic information on your case has to be taken into account. It's very difficult to say in your circumstance which is the right test, and that's why, if you remember when I gave the presentation and listed all those tests, I said the key thing is the skill of the clinician who sees you has to advise you what test to have and what not to have. Yes, you can have all of them, but it then becomes very expensive. And it might just be, if you've had to go to egg donor eggs, it might just be that you've just been unlucky with this first cycle. If we look at the success after using 3 donor egg cycles, the success rates will be well over 70%. So it is more than likely you'll end up having a baby and you've just been unlucky this time. So that would be the normal answer, not to have any test after one failed. But I think what I don't have information on is what happened with your 3 previous failed IVFs. So that is where that forensic information is required, and looking at you as an individual rather than just a generic answer.
All right, of course, understood. Thank you so much for this again. And well, I believe that now it will be our final question for tonight. And of course, there is a thank you from the patient for your right here as well. I do want you to see it. And the question that I have for you is right here. What would cause ladies with very similar AMH level to have very different numbers of follicles? Can IVF medication lead to increased follicles or just better growth of follicles already there?
So um, very good question. So so how can AMH levels have different numbers of follicles? And I think this is interesting. Um, the the mechanism. So anti-Mullerian is it actually it's actually there somehow in a way. Human beings have some systems within them that prevent them releasing too many eggs. So if you look at dogs and cats, very often they produce a litter of several puppies or kittens at the same time, while human beings have mechanisms that protect them. And the ovary is quite interesting. Some people also have what's called ovarian resistance, where they have very lots of follicles and a good AMH, but then they don't respond to stimulation at all. So these are just physiological differences between people. And again, I wouldn't worry too much about the actual AMH levels, and the same can also apply to the follicle numbers, because a lot of people want the numbers. Actually, what you're looking for is at the end of the day is a baby. Um, it's important to know whether it's high, normal, or low. Because if it's low, then you need perhaps sometimes a high dose to stimulate. If your reserve is high, then you need mild stimulation. And can IVF medication lead to increased follicles? Absolutely not. Because the follicles, you can't change the follicles that are already there. But what it can do is prevent those resting follicles that were asleep to make them grow. Now, if somebody has a very good reserve, you need to put them on a low dose so you only get a few of them up. If you give them a very high dose and all those follicles come up, you get ovarian hyperstimulation. Now, the converse is true, which is that if you have a very poor reserve and you have a high dose of medication, then um, you're not going to get too many follicles. And you might remember during the presentation earlier, I mentioned that if somebody was, so for a menopausal woman, no matter how much in stimulation you give, they're unlikely to produce any follicles. And many people might not actually know this. Well, um, um, IVF medication, FSH, was initially produced and still being produced, like Menopure, um, from from processing the urine of nuns in Italy, where their FSH levels are so high because um, they're menopausal. Then that so they then this urine is collected in these buckets and then processed because they've got such high FSH levels trying to stimulate their ovaries that they're menopausal. So that tells you that FSH cannot create more follicles. It can only make those follicles that that are ready to receive, that are receptive to grow.
And once again, wonderful. Thank you so much for that. And as I've mentioned, that has been actually our final question.
Wow,
So
it's been a
cute.
real pleasure.
It's been a great pleasure to have you here with us. So thank you a lot for your time. It's definitely our record, I think, when it comes
Yeah,
to the webinar time. So thank you so much for this.
I've enjoyed
And
it, so great. Thank you.
and we are definitely very excited to have you here as our presenter. And thank you so much for answering all those questions. And I just want to mention that, of course, if you have any questions more, you can go ahead to I will send you a link in a second, and you will be able to just simply get in touch with Dr. Valentine and his team. And I'm sure he will be more than happy to help you out. And thank you to everyone for joining us tonight, for all of your questions, lots of interesting questions. And of course, before I let you go, Dr. Valentine, there are some comments from the patients, and I do want you to see them. And there
Sorry,
is.
can't really hear you, Caroline. You're crackling. But I just want to say, I hope the information I provided will help a lot of people who've joined this presentation. I really hope it does, because appreciate how challenging and difficult it can be for patients. And I think one of the jobs I try to do is try and present things realistically rather than optimistically or pessimistically. So good luck to everyone.
Thank you so much, and couldn't agree more here. And as of course you can see, there are plenty of comments coming up your way. So thank you so much. That was a brilliant Q&A session, brilliant presentation indeed as well. And I just want to mention that, of course, remember, it has been recorded. You will have a chance to watch this again. It will be uploaded on our website, myivfanswers.com. And if you simply subscribe to our YouTube channel, you will be able to see it. You will see when it is uploaded. And I can only encourage you to join us tomorrow, as we will be back at 8 p.m. UK time. And there are plenty more of those events coming up as well. Thank you so much, Dr. Valentine. It's been a pleasure to have you here, and I do hope we will have another session with you. It's been a great and brilliant Q&A session. Thank you
Thank
so
you.
much.
Bye-bye. Bye.
Thank you. Take care. Good night and good day wherever you are. Thank you. Bye.